Hi, everyone. Thank you for tuning into Co-Designing for TechQuity. My name is Deyshna Pai, and I'm a senior at UC San Diego studying cognitive science and working as a product designer at UCSD's Diabetes Design Initiative. Now, some of you might hear the word designer and wonder, what does design have to do with healthcare? And my answer is everything. Designing for healthcare involves listening to everyday people share their stories about their experiences from their day in the life to specific instances such as seeing your doctor, using public transportation, or shopping for food at the grocery store. We design by drawing out an experience of your day in a journey map, a journey from the start of your day to when you go to bed. My journey map starts with waking to my alarm, eating breakfast, going to school, attending lectures, writing, designing before I go to my jazz rehearsals, and then return home to do homework and study before I go to bed and wake up the next morning to do it all over again. The depiction of my day like this is my journey map, and I'll use this again to share more about some of the experiences I heard working with people living with diabetes later on. And I should also mention that our journeys are heavily influenced by our identities. For example, my identity as an Indian American woman, a child of immigrants, and an older sister, to name a few, affect the specifics of what my journey looks like when I further flesh out this map. Now, I may not understand exactly what it's like to live with diabetes, but I can certainly understand what it's like to be misunderstood. Let me tell you my story and why I design for healthcare. When I was in high school, I ended up hospitalized on various occasions for intense stomach pains and spasms that would keep me up all night vomiting into the toilet. Across my various experiences of being sent to the ER, there were no obvious commonalities. The attacks always seemed and felt so random. And when I visited my primary care physician to talk about the pain I had endured or its possible causes at length, we didn't do any of that. Instead, she assumed early on it was my carb-heavy, fat-heavy Indian diet and handed me a pamphlet on the Mediterranean diet before she sent me on my way. Never mind that I was a minor living at home and that my diet was largely affected by my parents' roles as the primary chefs and grocery shoppers in our family. Never mind that consuming my family's cultural cuisine is a way I honor my heritage and spend time with them. Never mind that my physician didn't ask what my diet actually consists of and confirmed that I'm not eating Indian restaurant cuisine every night, which is very different from Indian food at home, by the way. Being prescribed the Eurocentric Mediterranean diet without being given the tools or the systems to implement change was how I left my appointment that day. And so when I went home feeling hopeless about the diet changes I needed to make, but knew were unrealistic to happen, I felt defeated and scared of the next time I'd experience an attack. What did help, however, was when I visited a gastroenterologist a few weeks later, who asked me, Deyshna, what's been going on in your life? How's school? How's living at home during quarantine? Is there anything worrying you at the moment? And it turns out that at that time, there was a lot. And my physical symptoms were very directly related to the impact my stressors were having on my mental health. Now, has anyone ever heard of the mind-gut connection? I hadn't before that day, and I wouldn't have if my gastroenterologist hadn't taken the time to ask me about my living experiences. And that's the reason that such reflection on my user journey is important. Here, and more pertinently, in taking ownership of our health. Because if we can extract scientific data out of processes as natural as getting out of bed, we can have a different conversation with our physicians. When was the last time that you had a great conversation with your physician? Unfortunately, we've learned from research that we have a long way to go. We know that it's tough being a doctor. They're asked to do everything in 15 minutes. So, how might we bridge these gaps and empower people like yourselves to initiate conversations that bring you that extra 30 seconds of value that you deserve at the doctor's? Introducing the checklist. Now, Thanksgiving is coming up. Many of you likely have your menus planned and your grocery lists written to match, and I'm sure that saves you a lot of time when you get to the store because what you need to buy and how much you need to buy is pre-planned. All you need to do when you arrive at Safeway or Ralph's is run through the aisles, grab what you need, pay, and go. Now, imagine shopping without your grocery list. Imagine going home and realizing you forgot to buy that one can of pumpkin puree that you needed at the store. Imagine the dread you feel knowing you have to go back, deal with parking, deal with crowds, the lines, and just the chaos from the holiday rush. Checklists. They save us time and they save us mistakes. And they can also do that for us in healthcare. Let me tell you about Dr. Gowande, a surgeon and author whose written works were largely informed by his experiences as a medical practitioner. He wrote this book called The Checklist Manifesto to address how professionals must keep up with their increasingly complex responsibilities in an increasingly complex world. Gowande talks to people in various fields such as pilots, construction workers, and doctors. Upon reading Gowande's book, Malcolm Gladwell notes that it's just too easy for an otherwise competent doctor to miss a step or forget to ask a key question, or in the stress of the moment, fail to plan properly for every eventuality. And he continues saying that experts, even though they're experts, need checklists, literally written guides that walk them through the key steps in any complex procedure. Gowande and his research team took this idea and developed a safe surgery checklist and applied it around the world with staggering success. And that's how we received the World Health Organization Surgical Safety Checklist. Let's take a look at some of the items on the checklist. So here we have a zoomed in view of part of the first section of the surgery checklist. We can break down the pieces of the checklist and analyze them for their effectiveness. First, notice that we specify the phase of action in our checklist. Right here, it's before induction of anesthesia. Now we can move on to questions specific to this phase that are going to help us get to where we need to go, such as confirm patient identity, confirm the surgery site, and verify the OR machines are prepped and functional, just to name a few of these tasks before we move on to the next phase of the checklist, which is focused on what to do before skin incision. And what we know about this system is that it works. The National Center for Biotechnology Information, the NCBI, published a research paper on a study done on the use of this checklist, and they found that the use of this checklist led to two things. One being significant reductions in both morbidity and mortality, and the second being increased teamwork and communication in the OR. Teamwork and communication. That should be a given every time you visit with your healthcare provider. It's this not having a formalized catch-all safety net during our appointments that probably explains why we also as patients confront shortened conversations, disconnected conversations, and walk away feeling unheard. When we started interviewing people of color living with diabetes, many of whom were part of the Diversity in Diabetes organization, we recognized that there were some consistencies that could potentially match up to a checklist of our own. So to recap, before a surgeon begins, we want to know that the right person is on the table, that we have the right site marked, that we have anesthesia that's ready to be administered properly, and that the machines in the room are functional. And when we see our doctor, we want to trust they will help us, to feel supported and heard, to receive updated information about new medicines and treatments, and to receive bias-free advice that is both actionable and helpful. And so, with these requirements in mind, we had strong inclinations to prototype a checklist of our own. But as designers trying to help people empower themselves, we always have a few questions to consider about the validity of our ideas before we turn them into designs. That brings us to prototyping. How do we do it? Well, we start by considering context. A 15-minute appointment is a limited amount of time. How long should this checklist be? Can't be too long. We've only got 15 minutes. Okay, if it's brief, then what about content? What's most important to include? How will format, whether it's physical or digital, come into play? And we can't really know if we're solving the right problem unless we talk to people. We spoke to many members of Diversity in Diabetes, as well as the founder of another DEI organization, because in order to design for the BIPOC community, we need to talk to the BIPOC community. This is called human-centered design. It's your experience that we're designing for. We can't have conversations about your health without you. And so we spoke to members of the diversity and diabetes community, and we collected your insights and threw them on this digital post-it board that we call an affinity diagram. We do this to cluster information and see what patterns stand out. Here's what stood out to us. These are real quotes we pulled from interviews. On the topic of getting the help you need, we heard, "Your doctor is your first barrier." I don't expect that anyone who gets a diagnosis is going to get the information they need. Oh, you're Black? We expect a type 2 diagnosis. I was misdiagnosed with type 2. My endo didn't listen to my concerns about our diet plan and told me I was a bad diabetic. Someone was diagnosed last month, and I sent them what they needed because they aren't getting referrals to diabetes educators. They aren't told about the multiple options they have in their care. They aren't told about technology. Diabetes is really personal, and it's important to see other people who look like me with similar experiences. Community helps me the most. And we could see patterns among these ideas when we made our affinity diagram, which we labeled with these orange post-its. What they say are the biggest themes we pulled from these quotes, such as, bias in healthcare is all too common. There's a stigma and lack of empathy that patients of color face in appointments all too commonly. That seeing yourself represented is really important, and that finding community with those experiencing similar things to you provides the kind of support that you might need that you might not get in your appointment all the time. And one participant, an African American woman with type 1 diabetes, working as an English professor, had a story that really stood out to us and matched with many of the consistencies that we heard in our interviews. Miss Professor was first misdiagnosed with type 2 diabetes when she ended up in a diabetic coma. For years, she listened to her body and knew something was wrong because she kept detailed data on her blood sugar. She made sure she had great A1C numbers and noticed they were going up, even while she was in shape and doing a 5K and eating low carb. She asked her endocrinologist to test her for type 1 antibodies and was denied. She got a second opinion from another endocrinologist about getting the type 1 antibody test, and she was denied there too. She flew to a conference and experienced DKA. When she went to the hospital, she asked to be tested for type 1 antibodies, which came back through the roof. It took her 8 years to receive the right diagnosis of type 1 after type 2. Your doctor shouldn't be your biggest barrier. Miss Professor also went a number of years without having received a CGM, including when she was on insulin as a diabetic during pregnancy. It was a stressful pregnancy, is what she told us, and she relied on her daughter kicking during sleeping to know about her lows, to wake up and to deal with her situation. When she found out about CGMs, she asked her endocrinologist why she was never told about them. And this is what her endocrinologist said. "I didn't think you could afford it. I didn't think you could afford it." When we hear stories like this one, we wonder, how can we trust our physicians? And Miss Professor's PhD couldn't save her from medical biases just because she was an African American woman. Even as a professor at a well-known university, she suffered from not receiving the right information about tools that could have eased her pregnancy and improved her quality of life. Her story confirms for us that this is not about education, but about race and systemic inequality. And it reinforces for us that when we talk about accessibility, we need to think about who we rely on for that access. And as a team of healthcare designers, it reminds us to keep the story at the forefront because these systemic barriers aren't going away. In summation, what we heard was people faced a lack of empathy for hardships and triumphs in appointments, leading to burnout. People faced a lack of actionable, culturally appropriate advice. And that representation and community helps fill in gaps and provide necessary support. We interpreted this as needing to feel seen, heard, and empowered. Seen in a story, heard with a checklist, and empowered by both. And so what we designed is a magazine that can be both digital and physical. Our magazine consists of the story, the checklist, which we paid a lot of attention to earlier, and our research also informed us about the importance of equipping our users with resources that would be helpful to them. So we created spreads containing general information about the types of diabetes technology available, financial resources to afford the help you need, as well as social groups to find supportive and inclusive community. Let's take a closer look at some of these features. Now, if you recall our World Health Organization checklist, you'll remember that for the surgical checklist, they organize their questions by phase and by an order. We did the same thing. Here's our during appointment checklist. This is a list of 4 questions you're meant to go through with your provider during your time of appointment. The questions are, is the person with diabetes aware of all the different diabetes technology related to diabetes management? Is there an understanding of the person with diabetes' current cultural and lifestyle context? Did we discuss all possible treatments for the person with diabetes? And did we allow time for the person with diabetes to ask questions? We also designed a reflection checklist for the person with diabetes to use after an appointment. The questions we ask here are, did you feel you were provided enough information by your provider to understand your treatment options and plans? Did you feel heard and listened to? Did your provider celebrate small wins with you? And did you feel like you could ask your provider more questions if you had them? In the physical version of this magazine, You can tear out these checklists much like you would a subscription form to a magazine. We did this to provide you with the flexibility to bring equity into your appointments consistently and always have these on hand to reference as you need them. When we heard, "I want to see myself in a healthcare situation," we understood that representation matters. Seeing that someone like you is experiencing things like you gives you a point of reference on how to navigate your own situation and hopefully makes you feel less alone. Maybe the next time someone is misdiagnosed with type 2 and still feels like there's something off, they'll be able to see a story like this in this magazine and know that they might be onto something about their own health and have that conversation with their provider until they get what they need. Because diagnosis doesn't mean a person always gets the information they need, we included a general information section on topics such as the different types of diabetes, the different types of insulin, different types of devices, and a QR code to learn more. A lot of people are unaware they can even ask about CGMs. We know CGMs are the go-to device to keep you in range and management. From talking to people, we learned that a lack of awareness is a huge reason why. We wanted to show people and give them that knowledge that they can ask for these devices, that they have a right to these devices. We'll wait for the slide to load. If you need help for your family, the financial aspects of managing your diabetes journey and nutrition, you can reference our resource pages. We compiled resources recommended to us by people of color living with diabetes to ensure that they'd be applicable and useful. And if you're looking for community, you can scan our QR codes to look up communities by diabetes type, by BIPOC and minority specific groups, and get involved with the advocacy groups that interest you the most, if you so choose. All these features, the stories, checklist, general information, social groups, and resources make up our magazine. And this magazine was designed with you in mind. We hope to give our prototype wings by conducting future experiments, testing our design, and by working with more members of the diabetes community. It's been a pleasure to share this with you today. For our next steps, we've written about our experiences using human-centered design as a method for user research discovery, which we hope to publish next year. If you're interested in learning more about this project or what we do as product designers at the Diabetes Design Initiative, feel free to visit our website at ddi.ucsd.edu or email us at ddi@ucsd.edu. Or you can contact me personally at deyshnapie@gmail.com and follow more of my work at deyshnapie.com. It's been a pleasure, and thank you for your time. I hope you have a great day.